The doctor is in, and I'm alone without Mo today, but I have an amazing doctor, Dr. Linda Vidal, who's going to talk to us. And I have, my dear friend, Haley Dinnerman, who saved my life, and my precious, precious baby breasty, Latoya, who's been on many times, my triple negative sister. And we're going to have a great conversation about a new trial, about a new therapy for triple negative breast cancer, which, is very close to my heart and Latoya's heart and Haley's heart, and now Dr. Linda's heart. So Dr. Linda, will you introduce yourself?
Hi, everybody. My name is Linda Vidal. I am a breast cancer medical oncologist. I've spent most of my career in New York City, so I probably met a lot of you who's in the New York City area, but I'm currently up at Dartmouth Cancer Center in northern England.
Oh, Dartmouth, where's my flag?
Dartmouth, exactly. It's a great place. And so I have a lot of roles here, but the thing that's really dearest to me is making a difference in triple negative breast cancer. And so I'm going to say, as you all know, we didn't really know that triple negative breast cancer was a thing probably until maybe about 15 years ago, 10, 15 years ago. And once we realized that it was its own entity, behaved in a very different way from than regular breast cancer, that we started to come up with strategies to really try to hammer it into the ground. And so, when I was in New York, seeing that this was something was really special and different, we started when I was at Cornell, which is the institution I did most of my work at. We founded a triple negative breast cancer clinic. We were able to bring in drugs like sacituzumab govitecan or Trodelvy, which was the first approved drug for triple negative breast cancer.
So that again, Trodelvy, that's how people know it, probably more than
Trodelvy, right? Trodelvy. We did the first work with Trodelvy, and our group said to, at the time it was not Gilead who owned it. We said to them, you know what, this drug really works well in triple negative breast cancer. You need to develop this drug in triple negative breast cancer, because they were looking to develop it in pancreatic cancer. And because of, we saw how well it worked, that sort of set them on the path. And that became the first antibody drug conjugate in triple negative breast cancer. And it's sort of set the stage for lots of other really active drugs of a similar, that are built a similar way. So, really, once we figured out triple negative breast cancer was something that was challenging, myself and my group, we just really dove into it. And what I want to talk to you guys about today is part of that diving into it is that we've really spent a lot of time trying to figure out how breast cancer spreads. Because when you think about it, if you could prevent breast cancer from spreading, then you could cure more people. And show you how we've sort of taken it from, just an idea, figuring out how triple negative breast cancer spreads, and then executing a clinical trial. And one of the things that I really want to share with all of you today is that there is a new clinical trial that is about to launch so far in eight places in the US. And I want you to be aware of it because I think it's really exciting. It's a completely different way than we've looked at trying to cure breast cancer in the past.
All right, Dr. Linda, go back for 1 second. I'm so excited about this. I'm so excited. And I know that Haley and Latoya have stuff to say, but so when you first started looking at what triple negative looked like and why it was different, right? And maybe you want to we always kind of reiterate and give kind of a definition of what it is. So you can do that for us in a second. But is it because people were dying? Is it because the drugs weren't working? Did you see it happening with Black women? Because I know the first national study I saw about Black women was from Leah Scott at the University of Georgia, probably about 2017 or so. But by then we had already known about it, but we hadn't known the effect on Black women from a national perspective. But when you first started seeing a difference in or recognizing, oh my gosh, this is a different cancer, a different breast cancer. Why? Is it because people were dying or the drugs weren't working? Or were you just looking at the science?
So I think it's a little bit of everything. So, it's the Human Genome Project that really start to put the focus on this. That we used to think about breast cancer in two ways. It was either invasive ductal or invasive lobular. That was it. When we would look at, markers, we'd look at the estrogen receptor and the progesterone receptor. And then we would look at the HER2 receptor or amplification when that sort of became prominent probably about the same time that the Human Genome Project came about.
So
Which
can you say, give a 2-second blurb on the Human Genome Project?
Yeah, so basically, lots of universities and the government got together and said, we're going to sequence the human genome. And I think that was like, I'm making this number up. It might have been like a $5 billion project, at the time. And each organization or university they had to sequence one chromosome, which maybe took them 10 years. But that's really what has opened up literally the floodgates in every disease to really
What does
understand.
sequencing a chromosome mean?
Can you say that again?
What does sequencing a chromosome mean?
Okay, so we have chromosomes in our body, which is all our it's all of our genetic DNA. So it makes us who we are, at least, I guess, biologically.
Okay.
And so there are billions and billions of codes. It's like writing code for a computer. It's our code. We each have our own individual code. And when that code like gets messed up, like the spell check doesn't work, then things go wrong in your body. And by knowing what's going wrong in your body, then you can come up with a strategy to fix that spell check. So when you think about people who have BRCA1 or BRCA2 mutations, even there are others like CHEK2, PALB2, there's a whole bunch of them now. Basically that's a spell check on the genes because cells are dividing all the time, dividing. And, sometimes they make mistakes when they divide, And so you have other cells that come in and they correct that mistake so that the cells are, I'm going to call them normal. And when you have a BRCA, when you have an inherited mutation in breast cancer, like a BRCA1 or BRCA2, that spell check is not working 100%. And that's why cancer cells can develop because you have errors in your DNA coding.
That's such a great definition. Thank you so much for that.
Okay.
That helps me a lot, helps everybody.
So getting back to the Human Genome Project and figuring out, looking at breast cancers and the way we used to think about it in terms of invasive ductal, invasive lobular, we would look at the hormone receptors, the estrogen receptor and the progesterone receptors, and then we'd look at HER2/neu. And HER2/neu is a growth accelerator that's present on some breast cancer cells. And so back then, and I lived this, so like I remember it, we would say, well, your tumor is ER/PR negative, which is not so good, but it's also HER2 negative, and that's really good, because we didn't have a treatment for HER2 positive breast cancer back then. But then what we used to see was that the triple negatives, the ER/PR HER2 negative, they always did poorly. And then we started to see data coming out from very large databases like, MD Anderson, Canada, Netherlands, where basically if you had triple negative breast cancer, your outcome in terms of recurrence rate was much higher than those who didn't. So we started to begin to think that, oh, wow, even though the ER/PR negative, not so great, HER2 is negative, that's great. You can't think about it that way. You have to think about the three of these things together. And that's what was sort of like born triple negative breast cancer, and supported by all the clinical information that showed that if you had it, it was worse. And then we started to look at ethnic and racial differences. And we said, wow, Black women have a worse outcome in breast cancer when you look at stage for stage, because you can look at an Asian Pacific Islander or white, you can look Hispanic, you look at Black, same stage, Black patients always do worse. And so it sort of became important, it became because people studied these things, they were able to see that in Black patients that they have higher proportion have triple negative breast cancer. And so that started to come out to explain some of the differences that we see in why Black women do worse than other ethnic and racial groups, because they have a high proportion of triple negative breast cancer. So there's something different about it. And that, basically put forth a whole new area of investigation to truly try to understand those biologic differences based on race and ethnicity.
Those
That's like the history of it.
On race and ethnicity. I'm so happy that you're saying that, and because that's what we're seeing as Black patients, that our breast cancer is different. So thank you so much for validating that and recognizing that, and hopefully making it better with your trial, right?
Yes.
You want to weigh in before Dr. Linda talks about her trial?
Me?
Yes. Yeah, either one of you guys.
So for those of you who don't know me, although I've been on the show a number of times, I'm Haley Dinnerman. I'm the
And I talk about you all the time.
I'm the executive director of the TNBC Foundation. I work so closely with Ricky and Latoya sometimes, and Dr. Vadat. We have known each other for goodness, like well over a decade. And we've been following your work even when you were at Cornell. You were one of the first doctors I ever spoke to who was doing research in TNBC specifically. And you know, the first time I heard about copper depletion strategies, you know, that was from you. So you've been doing this work for so long. And I know your passion for the TNBC community is, you know, and improving outcomes for metastatic patients is, you know, kind of what drives you. So we were so happy to have you on.
Yeah.
And I know our community, I mean, if you look at our discussion forums on TNBC Foundation, our private Facebook groups, there is so, you know, because we don't have a drug to prevent recurrence for TNBC, there is so much talk about research and clinical trials that are addressing that issue. And so that's why the trial that you're working on right now is so interesting to me and to our community.
Especially to our Black community, right, Latoya? And, you know, you did a trial.
Yeah, absolutely. I'm very interested to hear more about the trial that Dr. Vadad has been working on, like what phase it is in, and the objective of the trial. Because and you know, I really appreciate you know, in plain terms, but you broke down scientifically, like, hey, we, you know, as researchers, we saw that Black women were dying, you know, would have higher recurrence rates, and we saw that TNBC was more aggressive in women of color. And it's like, okay, wait, we see this difference, we see this, there's something going on. It may be something factor into genetics, and we quite don't know yet. But there's definitely an unknown variable, but you definitely lay it out that there is a known variable, that it is different in women of color. So I appreciate you for pointing that out, because that's very important for the scientific and also the non-scientific community to know that. So thank you very much, because we just don't know. We know that there's been, you know, cells identified in women of, you know, of African descent, like like Ricky, you know, one of the researchers I know you work with, the Duffy gene. So we know there's different genetics that that makes us, have a higher recurrence rate, and it's more aggressive. But we need to know why. We need to get to continuing the research to identify why, so that we can develop, you know, therapies and preventative strategies and things of that nature, so that, you know, our babies and our girls and, you know, my daughters can potentially not develop this disease if we can identify the actual reason why. And the only way we're going to get to that point is by continuing doing the research and continuing enrolling people in clinical trials and educating people. You have to, in order for you to get to the why, you have to study in order to get to that point. So I really appreciate that, Dr. Vadad.
And what to do. So what's your magic?
Yeah.
Ricky,
So I think the magic actually is the why. Is you're asking why, right? If you don't have an answer, you need to sort of figure out how you're going to get the right answer.
I think that before we even talk about your clinical trial, I think it's, you know, in speaking to so many members of the TNBC community, I feel like there are a lot of myths surrounding clinical trials that we kind of need to dispel before we even talk about the clinical trial, right? So for so many women, they believe that a clinical trial is what you do after, you know, as a last resort, after all other therapies failed. And that is just not true. Can you talk about it a little bit?
Yeah.
That is not true. That is not true. And especially to me, and you know, I'm not a doctor. I just play one on Facebook, right? but for a Black woman that's Latoya's age or younger, or a clinical trial is our best outcome, you know, and it's like getting the medicines of tomorrow today. So I think, you know, Dr. Linda, you know, talk to us.
That's exactly medicines of tomorrow today. And when I talk to patients about clinical trial, and you're so right, Haley, that, you know, there are certain preconceived notions. There's always, you know, oh, there's always a placebo involved. And most of the time there isn't, Most of the time, there isn't a placebo involved.
Mhm.
I feel like I'm being a guinea pig, and I think it, depends on what kind of trial you go into. I'm going to say most of the ones that are out there are phase 2s and phase 3s, and I'm going to say, there are different kinds of trials. Phase 1s are the earliest ones where they're trying to figure out the right dose and what the side effects are and where they should put a drug. But for the phase 2s and phase 3s, you already like have an idea. What is the drug dose, what are the side effects, what it can do, and you're testing it in a specific situation. So it might be, you're testing a drug in patients who've never had treatment before, and you want to see how well it works. So there are lots of different kinds of trials, and this is where I feel in so many ways it's important to have good communication, with your healthcare team to talk about trials and what is a good trial for you, and will it benefit you? Because yes, I know some people are altruistic. They say they want to benefit the future. But at the end of the day, I think people have to think about self-preservation and like, will this trial benefit me? And like, what's the likelihood of that happening? Standard treatments, we sort of know what they'll give. And if what they give is not acceptable to you, then you need to look for something extra. And those are most of the trials that we do. I mean, something extra, something that we think is better. And I always tell my patients when I talk to them about the concept of a trial that usually it gives, for the most part, it gives you access to drugs before they're FDA approved. And I've taken care of so many people through I don't even want to say decades, but who really have had drugs which are subsequently FDA approved that we've worked on. And that's just, they had the benefit of it.
Yeah.
That's
You're
great.
gonna be,
Haley
yeah.
and I were involved with Trodelvy before Gilead bought them at Immunomedics, and we had a great relationship with them, right, Haley? We actually did a
Yes.
event with them, and they actually helped build our TNBC Foundation website, right?
Mhm.
Absolutely. They really wanted, the community to understand, to feel supported and to understand, what the available therapies were. And I think that a key thing that I try to tell people is when you're in a clinical trial, it's not like you're not going to get standard of care. Isn't that?
Right.
You're gonna get a drug.
You
You're
have
gonna
to
You're
get
get
gonna,
standard. You have
yeah,
to
you're
get a
gonna
standard
get
of
that.
care.
But
Yeah.
That
people
is,
aren't aware. They aren't aware. They think that there is a possibility that they won't get actual treatment. Do you know what I mean?
Yeah.
And I think that
that
that is a
Yeah.
myth that really needs to be dispelled. That would be not just unethical, but
Yeah,
illegal.
I agree. That needs to be debunked. Like you're still gonna get you're gonna get the standard of care. You're gonna get, like I say, you're always gonna get the latest and greatest medicine for your disease in the
Mhm.
clinical trial. It's not what, and especially for minorities, like, you're thinking that you're gonna be experimented like a lab rat, or that, and I know that there's a huge, there's a huge misunderstanding because of medical mistrust, because of, really bad medical experiments as have happened before to African Americans. But that's not the situation of today. I'm a product of that. And
yeah.
Dr. Dr. Vidal, you mentioned something very, very great in the aspect of talking to your team. That's half the battle, because whether you believe it or not every physician actually discusses clinical trials with their
Mhm.
patients. We don't
Right.
even
Yeah.
get to that point. I mean, like, just getting to the point where it can be introduced and offered, that's half the battle, because I know I had to fight for that.
Yeah, we're not asked as Black women, but
No.
also the other point is that you have been working on this for years. It's not
Yeah.
like
Mhm.
you pull this out of your hat today.
Right.
You want to try it on somebody. This has been in your work for years.
It's a baby. It's a baby.
My
Get to the
baby.
point.
It's my
Yeah.
third child, and there's no tuition involved. Great. There's a
Hey.
lot of gray hair involved.
So tell us about it. Tell us about it.
So basically, I started looking, I'm going to say around 2000, for something that could maintain patients in remission. Because I don't know if you remember, a long time ago, there was a strategy to try to cure people with stage 4 breast cancer and high risk, what used to be called stage 2 breast cancer, where they used to give massive doses of chemotherapy, and then they would give stem cells. And in the end of the day, it showed that it wasn't any better than standard treatment. But the thing is you would have patients who had metastatic disease, they would have a complete remission, and they would stay in those remissions maybe for a couple of years, but then they would come out of it. So because I was involved in a lot of that research at the time, I was always looking for something that could keep people in remission. And that sort of led me to a clinical trial, which was being conducted at University of Michigan by Jeff Brewer and Sophia Mariver, where they basically had identified that copper was important for tumor growth. And so they conducted an early trial called a phase 1 trial, where they gave people who had a lump of cancer, you could see, they gave them an oral copper depletion pill. And then they looked to see how well it would shrink tumors. Well, the bottom line is that it didn't shrink tumors very well at all, so it was considered a failure. But what it did do was that it kept tumors from growing. And I actually knew one of the women that was in that trial. And so when I saw she had this metastatic disease, it didn't grow, she ended up dying of old age, I was like, this is pretty interesting. It must be doing something. So started to look into some of the research that was done. And there was a very interesting experiment done in mice, which reminded me of my breast cancer patients. Now, you might say that's a weird statement, but I'm going to explain it to you and you're going to understand exactly what I'm talking about. So in this experiment, they have these mice that are genetically programmed to get lung metastasis when they're 205 days old. Nothing happened, they just automatically get it. And so they gave half the mice a copper depletion pill in their water and the other half they didn't. And so as expected, the mice who didn't get the copper depletion pill, they got their lung metastasis when they were 205 days old and they died. But the mice that got the copper depletion pill, they did not get those lung metastases. But what was super interesting was that they basically, when they took that copper depletion pill out of their water, on average, 14 days later, they got lung metastasis. So that made me think that for some reason, when you depleted copper, that basically you could prevent the process of metastasis. Still were there, but like they couldn't complete, the metastasis couldn't complete the deal. And that actually made me think of my breast cancer patients. They could have no evidence of cancer and then all boom, then they've got something coming back. So what we did was that we went back into the lab and we started to explore this in a triple negative breast cancer model. And we figured out how it worked. And this is how, and I'm gonna summarize in probably 1 minute, 15 years of work. So basically, the way it works.
15 years, say that again, 15 years of work.
15 years worth of work. And, I have wonderful collaborators in the lab. Vivek Mittal is my collaborator in the lab. We've expanded the project to many other investigators across multiple institutions. But I'm going to tell you, this is how we figured it out. So basically, breast cancer cells, they're just sort of hanging out. They don't know how to get from point A to point B. So you just have it hanging out. So what it does, it is a mastered hijacking infrastructure in order to spread and grow. So what it does is that it hijacks cells from your bone marrow to leave a popcorn trail for these cancer cells to follow to a different site. When it gets to that site doesn't want it there. They're saying, go away. But what happens is that the tumor hypnotizes and hijacks cells to make a landing pad for itself on that distant site. So say it's a bone, it's a liver, it makes a landing pad. And the way it makes a landing pad is it makes a collagen landing pad. So the tumor cells land on that landing pad at the distant site, and then it's just sitting there because it doesn't have any infrastructure to grow. So what it does is it again mobilizes cells from the bone marrow to come out to put down blood vessels. And those blood vessels are super highways that bring nutrients to it, brings infrastructure to it, it builds a house, it grows. And those blood vessels are vehicles by which it can spread to other places. Now, the thing is it turns out that metals are super important in this process. I mean, none of this stuff can happen unless the metals in your body that we take in from our diet are there. And it actually turns out that copper is critical for each of the steps that I've described and many more. So putting all of this together, because we're clinical trialists, we said, well, gee, how are we going to test this in people to see, if we copper deplete people, can we prevent metastasis? So in about 2006, we designed a clinical trial in which we enrolled 75 breast cancer patients who had done what was considered standard treatment, but they were very high risk of tumor coming back. And they said, we want to do something extra. So our trial was something extra. And so what we did is we gave them a copper depletion pill. And then what we did was we monitored them over time, and we looked at the side, blood-based factors that basically are critical for tumor metastasis. And so the ladies, they were very, very dedicated. They came to see us every 4 weeks. we would examine them, we would do their bloods, we would make sure they're properly copper depleted, and then we would check to make sure no cancer would come back every 6 months with imaging. Patients who we were considered eligible were patients who had stage 3 breast cancer and patients who had stage 4 breast cancer, but had no evidence of disease. And by that, I mean that their cancer had come back. Somehow they got rid of it. We didn't care how they got rid of it. But when we looked at every modality, we had to evaluate them, including talking to them, physical exam, blood tests, PET scan, CAT scan. We couldn't find any evidence, but we know for those patients, 100% it comes back. I'm going to say about 2 years into the trial, it became evident that triple negative was a thing. And so we knew that patients who had stage 2 triple negative breast cancer have the same risk of recurrence as those who have stage 3 non-triple negative breast cancer. And we also got a signal that there was something special about copper depletion and triple negative breast cancer. So we basically extended our trial to have the full accrual for 75 patients. And so the results, well, first of all, the copper depletion pill, we call it tetrathiomolybdate, which is like a mouthful. So we call it TM for short. First of all, it was very safe and well tolerated. The only problem we had was we had a low white blood cell count when we over copper depleted people. And we did that in less than 3% of people. But when we started to look at our data in terms of our recurrence risks, we were pretty surprised because for patients who have triple negative breast cancer that's stage 4, the outcome is not good. And in our trial, and I'll tell you, our median follow-up now is over 10 years. 59.3% of patients didn't recur, which is unheard of.
It's huge. Almost 60% of patients didn't.
Almost 60% did not have their cancer come back who were triple negative and stage 4 NED.
Wow.
For our adjuvants, we had the outcome was that 88% of patients did not recur.
So
and
explain adjuvant.
Adjuvant and NED. NED is no
Yeah,
evidence.
no evidence of disease. So adjuvant, so those were we had 4 patients who were stage 2, and then I'm going to say we had 16 patients who were stage 3. And some of them had gotten neoadjuvant chemotherapy because this is before immunotherapy. And they're still, most of them still have no evidence of disease. And so one of the things
that go back, let's say that again. So basically the people, I'm just going to try to break it down.
Yes.
For the 5-year-old brains like mine. So the metastatic patients patients who had no evidence of disease, so though the cancer had gone to a different part of their body,
yes,
it wasn't doing anything to them. So they basically, am I
right? So they were fine. I mean,
they were fine.
They were fine,
but they weren't going to be fine for long.
If they had not taken the copper pill, they would have gotten.
Because I'm going to say the median survival, the average survival at the time was 11 months for stage 4 triple negative breast cancer, which of course is horrible. It's a little bit better now. It's like at 22 months. So there's definitely been improvement, but there's a lot more that we need to, there's a lot of room for improvement.
So even now, Dr. Linda, if you take immunotherapy like Keytruda or Trodelvy,
yes,
that's still 22 months.
Well, that's in the metastatic setting. So let's fast forward. Okay. So fast forward to, there've been improvements in the upfront care. Anyone who has a stage 1 to a stage 3 triple negative breast cancer, there's been a lot of improvements in how we take care of them. Yeah. Because I'm going to say when we started our trial, it was only chemotherapy, radiation, and that was it. Immunotherapy has actually made a difference. It's not a huge difference, but hey, we're moving in the right direction.
Okay.
So, and one of the things that we've done is that now almost everyone who has a triple negative breast cancer gets what we call neoadjuvant or upfront chemotherapy and immunotherapy. So if you have a tumor that's greater than 1.5 or 2 centimeters with negative nodes, you get upfront treatment. And what that does is that helps us select out what patients need extra treatment after surgery or not. Because
they get treatment before they have surgery.
Correct. Right? And then you have surgery. And then we bisect it into either patients will have some disease left behind that they take out or no disease left behind. And if they have no disease left behind, then you're going to assume that what you gave them knocked off any cells that could be floating around in their bloodstream. And right. So recurrence rates are actually quite low. it's 6% in that group. So those who have the technical term is pathologic complete response. So they get upfront chemoimmunotherapy, they have a pathologic complete response, they continue on their immunotherapy to complete 1 year, and their risk of relapse is 6%. There are ways you can further reduce that with a bone strengthening drug. We call it an adjuvant bisphosphonate. You can drop another 2.5% off of that. So bringing it down to about 3.5%. So we're in a much better place. But the thing
Right.
is that not everybody gets there. So I would say 65% of patients will get to a pathologic complete response, which is great. But what about the other 35% who don't have it? And those are the ones that we're actually targeting with our copper depletion pill, where we're adding our copper depletion pill. Because what we found was by adding in when patients took a copper depletion pill by itself, we saw these great results in triple negative breast cancer. But now we need to sort of move it to the next step to really try to prevent metastasis in patients who are getting what's considered standard treatment. So we have a trial that is about to launch in which patients who have a high risk of tumor coming back, so they had their chemoimmunotherapy, they had their surgery, they have some residual disease, it's unclear what is the best strategy for them. So there are many trials that are being done within the US in order to add more chemo or an antibody drug conjugate onto the back end to see if you could improve survival. But we're taking a completely different approach. What we're doing is that we are changing what's called the tumor microenvironment. So we want to interrupt the ability of breast cancer cells that could be floating around to hijack infrastructure to spread someplace. And that's what our copper depletion pill does. And so patients will take this pill with what's considered standard treatment, and they'll take this pill for 3 years. Luckily, it's well tolerated. We haven't really seen any issues. And hopefully less patients, hopefully no one will relapse. That's really what we want. We want nobody for their tumors to come back. And then if we're successful there, then we can move it to a phase 3 trial. But this is the structure of the trial. Now, if you really want me to get into the weeds, there are 2 parts to it. So the first part is that we're going to have a cohort of patients who are taking the immunotherapy, the capecitabine, and that's standard treatment, plus the copper.
Can you say the brand name for capecitabine?
Yeah, so Keytruda. So Keytruda, which is also known as pembrolizumab, which is an immunotherapy drug, because we actually find out that copper depletion makes immunotherapy work better.
And can I say that immunotherapy, just to define it, it's something that helps your immune system fight off the
Yeah.
And we know Keytruda is really doing great for women. We don't have really good data yet. I actually was at Merck this week saying I need some real world data about Keytruda because we want to be. So now this is good stuff on top of good stuff, right? With what we're doing here.
So the way the Keytruda works actually, is that for some reason, the cancer cells just like hypnotize and hijack everything. And one of the things they do is that they hypnotize your immune cells to not see them. So they sort of have an invisibility cloak on. So what the immunotherapy drug Keytruda, and all of them do really, is that they pull that invisibility cloak off the cancer cell so it can be seen, and then it revs up your immune system. So it's like a dual thing. So one of the things that we found was that, and one of the ways that it sort of has it puts an invisibility cloak on it. But the other thing that it does is it creates a moat around itself, like with collagen, because remember, it's hijacking everything, right? So it puts a moat around itself. So immune cells, even if they were to, not have, not even if your cancer didn't have an invisibility cloak on it, it has this sort of protective wall of collagen around it. So what we know with copper depletion is that you basically pull away that collagen moat around the cancer cells. We've done this in mice, and we've actually we've studied it in people with special collagen biomarkers. So there's lots of different ways that we make immune therapy work better with copper depletion.
Right. All right. So can you explain again? Or did you do your part 2?
I can explain again. Ask me a question.
Or just who's eligible for this?
Yeah, that's what I was gonna ask. I was like,
Yeah.
who's eligible for the trial?
Yeah. So,
Yeah.
women who have triple negative breast cancer, who've had some chemo or immunotherapy up front, who have surgery and then have residual disease. And there's a scoring system that we use for residual disease that came out of ND Anderson. It's called residual cancer burden. Basically, it looks at how big the tumor is, how much shrinkage you got from it, and it gives it a score. And so there's a score of 0, which is a pathologic complete response, up to 3. So patients who would be eligible are those who have what we call RCB 2 or 3. So pretty much any node positive is going to be an RCB 2 or 3. You have tumors that are at least 1 centimeter, they're probably an RCB 2, even in the setting of negative nodes. So our patients with triple negative, they did neoadjuvant treatment, they have residual disease, they are a candidate for this trial. And they have to be in pretty, obviously any trial it should be in pretty good shape. So if you just had a heart attack, you shouldn't be doing anything other than trying to recover from your heart attack. And you might say, like, why are you saying that? But I see that here all the time in New Hampshire. So.
And Linda,
So
it's a
go
pill,
ahead.
right? It's an oral therapy
Yeah, so it's a pill that you take twice a day.
twice a day. So you
So-
don't even have to come to the center.
No.
You don't
no.
have to
So-
receive your treatment.
Right,
Because
so-
I think it's important for people to understand, how their life would be disrupted by
Yes.
this trial.
Yeah, of course. So any patient who's going to be getting treatment after surgery, there's a standard of care. And that standard of care at a minimum, I would say, is a capecitabine or Xeloda, which is a pill. And it would be considered standard, although people are not too enthusiastic about it, to continue immunotherapy. And the reason why I say not too enthusiastic, because of data that came out of some of our trials that showed that there doesn't appear to be a benefit to immunotherapy in people who have a lot of residual disease. But I would say we're still sort of throwing the kitchen sink at them. So we continue it. So there's a standard coming and going to the offices for that. So when they and they will be on TM and be monitored during that time. So when they finish their immunotherapy and there's their capecitabine and they're just taking the TM, they'll come to the office every 2 months.
So you have to have some residual disease in order to be part of the trial.
Yes, exactly.
And you're probably going to be taking Xeloda too. Is that what you're saying?
Yes, you will be. So
Okay.
so the way we sort of wrote our trial was that because I think some practitioners will be enthusiastic about giving Keytruda in the adjuvant setting. So that's after they, after their surgery, and others won't. Also, sometimes people can have side effects to immunotherapy, about 15% of people. So we sort of left it up to investigator discretion, whether or not they wanted to continue the immunotherapy or not.
So Latoya and I are not candidates because we both have no evidence of disease, but my gut says I want to take a copper pill. I mean, I'm 12 years out now, almost 13, but Latoya is like a year out, right?
Yeah.
A year and a half.
Yeah.
Why
But
would-
I didn't have a PCR. I didn't have a PCR. I'm just gonna be clear, I had an incompetent oncologist, the first one, and I fired him because I wasn't offered Keytruda. I asked for clinical trials that was not offered to me. And so I was robbed, and you also mentioned about adjuvant bisphosphonates. I was robbed of those 3 things. I was not offered those 3 things in order to have a chance of having a PCR. So what that entailed, I still had residual disease. I had a great response, but my tumor did shrink down from like 5.5. I had a very large tumor. I had a 5.5 centimeter tumor. I was 3C. And then it shrunk down after neoadjuvant chemo. It shrunk down at the time of surgery. It was like 1 centimeter. So with that, and I still went on to fight for a clinical trial that consisted of just looking at baseline ctDNA. My PI said no at our institution at Georgetown. She was like, no, we're still giving Keytruda. And I received Keytruda and I received Xeloda together.
Right.
Yeah, so I received that together. So I guess my question is now, like, so technically, yes, as of today, I'm NED, thank God, but still, I still had, I don't know what my RCB number was.
Might have been, it could have been one or two. It's like, I haven't quite figured out how to
Yeah.
like translate it, but it might be in the path report, especially for a place like
Yeah,
Georgetown.
sure
Is
it's
it
in the
Georgetown?
path report. So
Yeah.
you're saying that for your trial, you need people to have some type of tumor burden still in their body, or I
Yes.
guess I want to be clear on that. Okay.
Yeah, because we're focusing in on the people who have the highest risk. And that's
Right.
35, non-PCRs are 35%. So those are the people that we really want to help.
And they
Which
can
would,
benefit.
Yes,
Yeah.
exactly.
yeah,
So
which I would still be in that category too, if you're basing it off that, because I didn't have a complete pathological response. Yeah. Okay.
So yeah, I'm trying to figure out, like, I want to take it too. Like,
I
I'm
know.
copper is.
We can talk offline
We can talk offline, but
about
no,
that. I mean,
like,
there are
I feel
ways to
like,
get it. There are compounding pharmacies who do
yeah,
provide this off
but I
trial.
feel like anybody who had TNBC, I'm very blessed. I don't know what happened. God intervened and I'm here, right? And I think that, but anyone who had it, I want to take it. I want to try it. I would recommend it to anybody, and I'm not a doctor, but I mean, to me, it seems like a simple, easy thing to do. Take a copper pill, and if
Especially if it's well tolerated.
Well,
Saying-
we're really excited about it, but we know that if we want to move this forward, that there are trial designs that have to be done in order to move it forward. So our trial design after our phase 1B to establish the safety of immunotherapy, capecitabine and TM together is a randomized phase 2, where there's a control arm, which is, does not have TM in it. There's no placebo in it, but so everyone knows what they're getting. But that's the only way to be able to move this forward. Now, the good thing is that, in these kinds of trials, if you see a difference between the two arms, which and the endpoint for the trial is distant relapse-free survival. So we're trying to prevent metastasis. Then you can basically stop the trial early, and the control arm can get TM. But that's the only way in order to move this forward. So, I mean, I do strongly believe in it, but you have to prove these things in the proper way, or else you're not helping anybody.
Yeah, so break that down for our audience. So basically there are two arms. One of them you're gonna get a standard of care drug plus the TN, the copper. The other one, you're not gonna get the TN. However, after a period of time, you can get the TN. You can get the copper.
Well, sort of. So there are two arms. One is standard of care, which you would get no matter what. And then the other arm, they call it the investigational arm, is standard of care plus getting the copper depletion pill. Built into all these trials are early evaluations looking at the data to see, well, if you see a big difference and we see a benefit to the TM, then you stop the trial and you say success. And then the people who didn't get it, they can get it. But the thing is you have to study it in this way, or else you can never move things forward.
Right,
Ever.
right. That's how most trials work. So.
Dr. Vadat, may I ask a question? Because I just want to be clear. When you're saying copper depletion, so are you taking a pill that's depleting any natural levels of copper, or are you taking a pill that's actually replacing copper into your bloodstream, that's adding copper into your bloodstream?
No, it's depleting it. So when we take copper in, we take it in through our diet. And so what this pill does is it binds the copper we take in through our diet, and we just excrete it. So it doesn't, and the way I sort of think about this is, you got a pool of copper in your body, right? Because you're eating it, it's going into the pool, some of it's being used, some of it's being stored. So for some reason, our normal cells are at the head of the line drinking from that pool. And what we want is that the cancer cells are at the back of the line. And so we want that by the time that the cancer cells get up to the head of the line to drink from that pool, that there's nothing left for them. But we want copper to be there because copper is really important for normal cell function. So it's a balancing act.
This is so cool.
So interesting.
It sounds.
We figured out a lot of how it worked. We think and not all
cool.
tumors use copper, but we think we have a biomarker that we're going to be looking at. We've built a lot of science into our trial. because this is gonna really help us figure out which tumors utilize copper the most, which are the patients that might benefit the most. And so we've got a lot of science built in, and we're really excited to finally start. So it looks like we'll probably, I want to say August, but okay, let's say September. In bad case, we'll be open in September. But we have 7 other sites up and down the East Coast who are
What are
partners.
Yeah, what are they? What are they? So you're at Dartmouth, you're in
So we're at
Hanover.
Dartmouth, and
We're
we
not
have,
too many Black people, but we'll find them.
there aren't that many here. Only 0.6%, I think so 0.6% of the
yeah.
population. But NYU, Nancy
NYU.
Chan is the director of breast cancer research there, and she's a co-principal investigator of this trial. She's also, when she was a fellow at Cornell, she worked on the trial with me. So I'm really excited to have her being, my comrade in arms on this. So we have NYU, we have Vanderbilt, Ben Park, who's the cancer center director, is partnering with us on this trial. Emory, Kevin Kalinsky is our partner.
Right.
University of Indiana, Nancy Miller, Houston Methodist, Jenny Chang, at MSK, Mark Robson, and at MGH, it'll be Nalima Vidula. So that's where we are. And
What was
since
the last one? What was the last one? And
MGH, Mass General.
that's general. Okay.
So we have a bunch of sites, and the reason we don't have more is because this is how much we could afford. We do not have a pharma sponsor. This is all investigator initiated. We have, a company who, and we've partnered with NCI on this, by the way, the National Cancer Institute. So they and a small company and a company in Florida are making our drug and our pills for us. The NCI Next program at the NCI has been amazing to work with. We have Gateway Foundation, who's funding part of the study, Breast Cancer Research Foundation. We have 2 R01s where we have the Margaret Claire Pisani Fund. So we're almost fully funded. Right now,
That's awesome.
this week we're sending in a DOD to help to get some of the science paid for. So, and expand our sites, because we really want to set in California.
And
So
for those people who might not, for those viewers who might not know where all of those institutions that we just listed are located and want to know if they're near them, would you just list the states?
Yes. So Emory is in Atlanta, Georgia. NYU is in New York City. University of Indiana is in Indiana, but I'm Indianapolis. Houston Methodist, Houston. Memorial Sloan Kettering, New York City. Mass General in Boston. Vanderbilt in Memphis, I think it is.
Nashville.
Nashville, sorry, Nashville.
Yeah.
Tennessee. I've never been there, so
Beautiful.
There. It's beautiful.
So
can you do it via telemedicine if you're not in any of those cities?
Oh, so the telemedicine rules are draconian now. So basically, you cannot do telemedicine unless you have a license in that state and you have malpractice covering you in that state.
So it's really for people in the States. Okay.
Yeah.
All right. So we have to get more locations for you. But so with blackdoctor.org, we often write articles about what we talk about on the show. And so I'm going to see if we can make that happen so people have a good understanding, and we'll have it on their website. And regardless, we will put all this information on our social media so people can have access to it. And you guys know how to reach me, Ricky at touchbbca.org, but we will put you in touch with Dr. Linda. But Dr. Linda, is there a way for people to reach out to you or reach out to,
yes,
sort of get
we actually have an email address, and I think, I don't want to give you the wrong email address. I would have to
later. We can put it in
yeah,
later.
because we had it set up, and then we were like, we're not getting any emails through. The person who set it up left, and so we need to make sure that it comes to a box that it's going to be like TNBC Copper Study at hitchcock.org, but I have to double check that.
When you get it, we'll put it in the information. We'll put
yes,
it in
that'll be great.
And we will make everybody know about it. But because I think this is, miraculous. My new word for unicorn is mermicorn. So I love the water. So I think you're a mermicorn. You're finding something that, I mean, well, you can see my two hashtags behind me right here.
Mhm.
GSG and DIS, do iconic shit.
Mhm.
But we're,
But
honestly, Ricky, we are so excited, and it's like part of like, I mean, metals have been completely understudied. They're definitely on the radar now with some high-end publications, coming out.
it's like, seems like
We are
so
looking to do a Metals and Cancer Institute up here. We have a trial in lung cancer because as I said, it makes immunotherapy work better with immunotherapy. So, we feel like things are moving forward.
I think it's so cool, and it seems like such a simple thing, but 15 years in the
Yes.
making. Hello, so, but I think it's something that we should all be jumping on, and I know it's going to save lives, and we're so grateful for your science, and we just need more of you in the world to make this science happen. We want to help you try to get Black women into the trial, and we are going to do that aggressively. So however we can help you, and if people have questions, please call us and we'll put you in touch with Dr. Linda. But it's so important that I really believe that clinical trial participation needs
Mhm.
to be commensurate with the burden of disease. And we're
Right.
getting triple negative Black women at 3 times the rate of white women. And so we have to reflect those numbers in your
Yeah.
trial. And that's what I try
Yeah.
to do with you. Get more of us in the trial, and then figure out how we can, just, grow the
And
number.
and that's why, when I chose the sites, and reached out to my friends at those sites, I knew that they would have, large numbers of Black women,
Mhm.
NYU,
Yeah,
Vanderbilt,
Atlanta, Emory,
Emory. I
Houston.
actually, we reached out to UAB, but they were too expensive for us. They were like double the price of everybody. And, I haven't, this is investigator initiative trial, I have limited funding. So, I think if we get our DoD grant, I would go back to them because I'm going to have more money and I can, afford them. But like right now, I don't have enough
UAB?
money.
What's UAB? What's UAB?
University of Alabama, Birmingham.
I just wanted you to say it.
Okay. Okay.
Yeah.
Great,
But I
great,
think
great.
you did such a great job of selecting trial locations that
Yeah.
would enable us to have diverse participants.
Yeah, diverse participation. And, I've worked with all these people before. I really like them. They've been following the progress, that we've made through the years. So I'm really excited to finally
Okay.
get it up and run. It's like, oh my gosh, so many.
Dream. It's a dream many, many, many years in the making. I
Yeah. And
let's
so
go
many
back to
people
when you
working
were
so
here.
hard.
Mhm.
Yep.
Yeah.
And what, for our audience, can you explain maybe the difference of what you're doing as a physician versus what a pharma company is doing? Because a pharma company comes in and does trials, and we work with many of them. We work with pretty much all of them that are making breast cancer drugs, but they come to this a lot of money and a lot of resources and a lot of whatever. But to you, as an individual doctor doing this, it's phenomenal. It's amazing. And so if we can support you in any way, we're so happy to do that, because it's going to save lives. It's going to save our
It's but like I said, it takes a village, because I could not do this without literally hundreds of people to help. And I feel like, we're all moving in the same direction, and everybody has the kinds of things that they can contribute to help. So, when I think about, my scientific colleagues, they're like deep in the weeds into like why things work, how things work, and that's really key. I'm grateful patients, patients have been on these studies, they've raised a ton of money for me. I'm going to say 2/3 of the money for this trial has been raised philanthropy, because they are, they know that in order to move these things forward that are promising, it takes a village. On the clinical end, our project manager is someone who's worked with me literally for 15 years, and she's took care of our pilot trial. And now she's leading, the coordination for this multi-center trial. And then, of course, Dartmouth, that has the vision that, oh, no one's done this before, no problem, let's get it done. So really
Yeah.
it takes a village, and
I know, and I'll
I'm
have
just
Dr.
lucky to be working with them all.
And Dr. Mo teaches at the med school. So the next time she's up in Hanover, I'm going to have her come talk to you.
Love
She
to
teaches
that.
she has a DEI class for first year students. I actually taught it with her one time, which is pretty cool. But I'll have her come meet you and reach out to you because she'll love that. I'm so sorry she's missing this conversation. But if we could be part of your village to help you recruit patients, we are in
That'd
all
be
the way.
wonderful.
And we're happy to spread this word and get it out there. And if you guys are watching and you know a TNBC patient, you have somebody in your family or somebody you're connected to, please share
Yeah.
this episode.
Even just to
and
get more information to see if it works for you, you know?
if it works for you, because if we can prevent recurrence, I mean, and again, Haley said it earlier, we are the only breast cancer subtype that doesn't have a drug to prevent recurrence.
Right.
So be like a first ever.
Yeah.
This tamoxifen, this is like this could potentially, well, without all the
Yes, that's exactly right.
side effects, potentially, you know, like this could be, yeah, this is groundbreaking. This is definitely groundbreaking.
It could be, but we have to develop it right so that it doesn't get
Do the
it
right
doesn't
thing.
get lost because we didn't develop it right.
Right.
And
That's what the clinical trial is for. And then
Yes.
everyone
That's
should know that there are, you know, if this is not a clinical trial that a certain person can participate in, but they still want to look at other clinical trials, TNBC Foundation has a clinical trials matching service on our website. One is specific to all triple negative and one specific to just metastatic TNBC. So you can check those out.
yeah, TNBCfoundation.org. And you know, we also have a portal on our whenwetrial.org site for trials, as well as trial matching. So we can help you in both. We can help you either way. And we are happy to help you find the right trial for you if this isn't it. But I think this is like a wonder thing. And so,
yes, we're excited. So we're almost there. Almost there.
keep us posted. Let us know when it starts. And if
Yep.
you have any social media stuff to put out there when you're ready, we're ready to blast this message out. And
Very exciting.
Yeah.
We're cheering you
Very.
on. We're really rooting for you because we need this, right? We need this.
Yeah, and it helps, you know, triple negatives, but also it has the potential to help others also with some of the backdoor science that we're doing. You know, I mean, we need something new. You know what? As an oncologist, I am tired of giving chemo. I don't want to give chemo anymore. I want something that's more targeted, you know. But that's what we have.
Yeah, and that's all we have. So we need, and I say that every day, we need better drugs, we need more therapies, we need different stuff, we need to be iconic. And thank you for your brain for thinking of this and getting out of your box, because we see so just get stuck. Okay, I did it this way last year. Well, it didn't work last year, so this is going to work and save lives. And we can't thank you enough. So thank you for being on
so much.
Thank you so much. Thank you for your dedication.
Yeah, thank you for your commitment to doing this for so
Absolutely.
staying with it and finding a way out. So
Oh yeah, I'm persistent.
I love it. I love it.
Okay.
Thank
Take
you,
care,
Haley.
everybody. Thank
Bye.
you. Have a good weekend.
Take care, everyone.
Bless
Bye.
everyone. We'll see you next week. We'd like to be real, reliable, and relatable, as Mo would say if she were here. And thank you for our platform with Black Doctor. Thank you for our sponsors, and we're very grateful. Bless you, love. Bless you, love. Thank you, Dr. Linda. Bye-bye.
Thank you.
Bye.
Bye-bye.